I'm Giacomina Massaro-Giordano. I'm a comprehensive ophthalmologist at the University of Pennsylvania, associate professor, and I'm co-director of the Dry Eye Center at the University of Pennsylvania also, and I'll be talking to you all about dry eyes. And you can see the title of my talk doesn't say dry eyes, but says tear dysfunction syndrome. And why tear dysfunction syndrome? Just to start out, the name dry eyes in many situations doesn't make much sense, because there are people who have dry eyes, but in fact their eyes are wet or moist or mucousy all day long. And it really is a problem with the tears and how they interact on the surface of the eye. And in many situations, your eyes aren't dry with dry eye syndrome. So a better term to use would be tear dysfunction syndrome. And starting out with this syndrome, I'd like to let you know that it's very, very common ocular surface disorder with numerous etiologies. 20% of the US population is diagnosed, but the percent of individuals that experience symptoms is actually much greater. Unfortunately, it's a condition that is often ignored. Lots of people have it. The Pope has dry eye. Former President Clinton suffered from dry eye when he went to the Arab nations. Very common, and it's gaining a lot of attention because we're finding that as time goes on and people are getting older and are healthy and living into their 80s and 90s, what's holding them back is this tear dysfunction syndrome. It affects, in a very negative way, their quality of life. And they've done studies to look at this, where people with dry eye rate their problems as high as someone who has angina or heart problems. It affects it to that degree. And because of this, lots of research has stemmed for dry eye, and many more centers are becoming aware of this condition, and there are specialists that are actually addressing the issue for many of these patients. So what do patients experience with dry eye? You can get just blurry or changeable vision. That could be your only symptom. You can get what's called transient visual obscurations, where you can see something and all of a sudden it seems to fade away and then it comes back. Patients can experience irritation. They can experience burning, redness. They can be light sensitive. And this is the tricky one here. Many times patient will have itchy eyelids from a dry eye condition. So what do? They think, oh, I must have some sort of allergic condition. And they go to local pharmacy and they grab an over-the-counter artificial or a teardrop that treats allergy. The problem is the anti-allergy drops are very drying to the eye, and that can actually make things worse. So it's very important to see an ophthalmologist and see, are your eyes dry? Do you have tear dysfunction syndrome? Or do you actually have an allergic conjunctivitis? So the symptoms can overlap with other pathologies. The other symptoms that patients can experience is pain. And why would they experience pain? Well, people who have severe dry eye or even moderate dry eye, you can have a situation when the cells on the surface of the eye or the cornea start to lift off from the dryness. And when they lift off, you get these microcorneal abrasions, very painful. They heal up very quickly. So this is where the problem lies. You go to the doctor the next day and it's already healed over and they don't see the drying symptoms. They don't see the signs on the surface of the cornea. A few words about the tears that we produce on the surface. We make tears which lubricate the eyes all day long, and then there are tears that we make in response to irritation or emotion, and they're chemically a bit different. With dry eye, you can get into a very vicious cycle, because in the early stages of dry eye, patients can actually have excessive tearing, which I'll explain in the next slide. But over time, when the surface dries out or the tears are abnormal on the surface, you can get increased inflammation on the surface of the eye, which then can damage the cornea, which is the window that covers the surface of the eye, and the cornea becomes less sensitive to various stimuli. So if the cornea becomes less sensitive, there's less of a signal to the brain to make more tears. And over time, you make less and less tears with dry eye or tear dysfunction syndrome. So you get caught into this vicious cycle. The early stages of dry eye, interestingly enough, a lot of patients will come to my office with tearing as a complaint and irritation. They tell me they're tearing all day long. And I'll do a thorough exam, and at the end of the exam, I'll tell them that they have dry eye. And they look at me and almost want to run out of my room. But I explain to them the tearing is an early symptom. What happens when the surface of the eye dries out or gets irritated, in the early stages of dry eye, there's a signal that's sent to the brain to make more tears, and that signal then comes back to the lacrimal gland, which sits on the side of the lid, and the lacrimal gland will pump out more fluid on the surface of the eye. And so in early stages, their eyes will tear all day long, and where you stop that is if you just start hydrating the eye or putting artificial teardrops in, that tearing will diminish. The other reason that they may tear, and I'll always make sure they don't have this, is they can have a block in the system. In our eyelids, we have these little drains that sit in the inner portion of the eyelids. They're drains that should be open. If they're blocked for some reason, then the tears that you'll make will drip down the side of your face. And for a lot of these patients, that's the reason for tearing. So it's very important that your ophthalmologist decides, are you tearing because your eyes are dry or irritated, or are you tearing because you have a block in your system? They're two different pathologies. Few words about the tears themselves. It's not just water. Tears are not just water. They're actually very important components that make up the tears that cover the surface of the eye. The first component, which is the most important, is oil that comes from the meibomian glands, which live in the eyelids close to where the eyelash roots are. Very important glands. The function of these oil glands is to seep out of the eyelid and cover the surface of the eye and coat the tears that you make. So oil is a very important layer. Second important layer is the water layer that comes from the lacrimal gland that makes the fluid. And then the third layer is the mucus layer. It's very important to have mucus on the surface of the eye. They all work together to keep the surface of the eye constantly covered. And the mucus comes from very specialized cells called goblet cells that kind of reside on the skin covering the white part of the eye. So, point here, it's very important to have all three layers. If you're missing any one of these components, you can have a specific type of dry eye. When I see a patient in my office, I really try to decide what is causing their dryness because the treatment is very different. And I break them up into two categories. Are their eyes dry because they're not making enough fluid from the lacrimal gland, not enough water? That's one type of dry eye. Or are they dry because they're making the fluid, but the tears are just evaporating off too quickly? So that's evaporative dry eye. It's very important to know which type you have because the treatment is different for the different types. So right away I try to break them up into evaporative dry eye or not making enough fluid. If they're not making enough fluid, I start thinking, do they have some sort of autoimmune process that's attacking the lacrimal glands that makes the fluid portion? Or have they had an infiltrative process of those glands? Have they had radiation to the area around their head or their face where these glands aren't functioning? And that gives me one category. Then evaporative dry eye, which is really the most common type of dry eye. In my practice, 60 to 70% of patients come in with evaporative dry eye. And where does that come from? Well, I take a very close look at the lids. The lids have to interact with the eye in a very special way. If someone comes into my office and they have eyes that look like this, they probably have thyroid eye disease. And their dryness is coming from the fact that so much of their eyeball is exposed because their lids are pulled backwards and their tears are evaporating off. They're making plenty of tears, they're just evaporating off very quickly because of their eyelids. Or if they have an abnormal eyelid with a scar that's pulling this eyelid down, that's a type of evaporative dry eye that has nothing to do with the amount of fluid you're making. When you correct this eyelid, their dryness goes away. Same thing here, if the eyelid is turned inward. So I work very closely with the oculoplastics team when patients come in with symptoms of dry eye. If it's the way the lid sits next to the eyeball, we can fix that and fix their dry eye problem. I also ask in history, many times patients' eyes dry out at night because of just the environment. There's people who sleep with CPAP machines for their sleep apnea. And with that machine, there's constantly air blowing over the surface of their eye, and that will dry out their eye. So many different reasons. But I'm going to get into a lot of detail about the very common reasons, a condition called blepharitis that inflames the eyelids that can cause dry eye. But before we get to that, how do I diagnose the different types of dry eye? Well, I do a thorough examination, and I look at a couple of things. I put in a stain on the surface of the eye called fluorescein. It's a yellow stain. I put it on the surface of the cornea, and then I count to see how many seconds it takes for this stain to evaporate off. In a normal person, this stain should cover the surface of the eye for about 10 seconds. If I start seeing the tears evaporate off within 2 to 3 seconds, then I know they have some sort of evaporative dry eye condition. So that's a very important test. Then in some situations I'll do what's called a Schirmer's test, and this is when strips of filter paper are placed in the outer corners of the eye, in the eyelid. The patient keeps their eyes closed for about 5 minutes, and I look to see how much tears they actually produce in that 5-minute period of time, which can be very useful to know. Then the ophthalmologist will use very special stains that we use to put on the surface of the eye. One is called rose bengal, one is called Issamine green, and depending on the staining pattern, that will also help me diagnose different types of dry eye. Here you can see just barely a little bit of green stain on the white part of the eye. That's abnormal. That's someone with tear insufficiency dry eye. When we put the fluorescein stain in, if we start seeing all these little dots of yellow, that's also abnormal. Those are areas of the cornea that have abraded off. This is damage to the surface of the cornea. So we look for all these signs. And there are also now some very specialized machines, wavefront analysis that we can do. And just recently, through our dry eye clinic, in some of our study patients now, we're able to actually measure osmolarity. Now, what's osmolarity? Osmolarity is how concentrated your tears are. If someone is very dry, they have a higher concentration of tears because the fluid evaporates off, so their tears are more concentrated. When the tears are very concentrated, that can actually irritate the surface of the eye. So we finally have a machine that will actually give us a number of how concentrated your tears are. And they've done many studies to look at this, where the cutoff range is usually about 360 milliosmoles. If you're higher than that, you're usually dry. If you're lower, you're probably okay. Because the signs and symptoms with dry eye can vary so much, it's nice to finally have an objective test, a number that we can equate to the severity of dry eyes and also help with treatment. If someone's diagnosed with dry eyes and we start treatment, we can do this test and see if the osmolarity has dropped or has fallen into a more normal range. Now back to that blepharitis. This is a general term that means inflammation of the eyelids. There's all different types of blepharitis, and it's very important to know if you have this condition because, like I said, 60 to 70% of my patients will have this condition, and this is what's causing their eye to be dry. It's a type of evaporative dry eye. So what I look for is I look very closely at the eyelids, and I look to see at the base of the eyelashes if all these deposits live there. These deposits are just crusting of the skin, and bacteria can live here, which can irritate the eyelids. These pieces of skin or bacteria can get onto the surface of the eye and cause the tears to evaporate off more quickly and keep the eyelid very inflamed. There are different types. There's an anterior type that affects the anterior portion of the lid, which can be to seborrheic changes, skin conditions that can occur on the lid, or a very common condition, which really goes misdiagnosed many times, is something called Demodex blepharitis. What I'll do in the office, I'll pluck one of the eyelashes, and many times looking under a microscope, there can be mites that live in the eyelashes. Very, very common, very, very difficult to treat. But it's important to know if you have this type of blepharitis. So that's the anterior type. The next thing I'll do is I'll look beyond the lashes and look at this rim of the eyelid margin. And I look very closely to those very specialized oil glands. These are called meibomian glands. And if I see that they're clogged up, like in this patient, this looks like toothpaste coming out of these oil glands, I know right then and there that they have posterior blepharitis causing evaporative dry eye. Why? You need this oil to come out in a clear solution and coat the tears. If the oil is not coming out of the eyelid, you cannot coat the tears, and your tears that you make will evaporate off quickly. So understand this. These people are making the normal amount of tears, they're just evaporating off too quickly. Very important to know, because these patients will have symptoms of itchy eyelids, foreign body sensation, grain of sand in the eye all day long, red eyes, and just very important for the ophthalmologist to take a very close look at the slit lamp and look at those eyelids. Another cause of dry eye, which also goes misdiagnosed because you really have to look for it, is a condition called conjunctivochalasis, crazy name. What it means, the conjunctiva is the skin that covers the surface of the eye, the white part of the eye. And over time, it can get very loose and can get very boggy. If that skin gets loose, you know, these patients start to experience symptoms with tearing, and they have a hard time when they're reading, because when they're looking down, it kind of crunches up that tissue that's very lax. So I do special tests in the office to see if they have very loose skin covering the surface of their eye. If they do, that can be excised and then sewn up and made flat again. And many times that will solve up their dry eye condition. So it's really important for the ophthalmologist to look at the eye very closely to see what is causing the dryness. Once we find out what's causing the dryness, well, then we'll either replace the tears, conserve the tears, or prevent the tears from evaporating. And there's various different techniques which I'll go into in just a few moments. And I wanted to stress that many times people think people who think they have a dry eye condition think, all right, well then I must need artificial teardrops. But I want to stress that with dry eye, it's not just artificial teardrops. In some conditions, it isn't artificial teardrops at all. So for an artificial teardrop, and I'll get into this later, if you're going to be using a teardrop, you want to make sure you know what kind you're using. I'm going to talk a little bit about the ones that are preserved and non-preserved. For patients with blepharitis or meibomian gland dysfunction where the lid is the major problem, then the treatment for that is very different. What I want to do is stabilize those oil glands and get them to function and cut down the inflammation in those oil glands. And that regimen consists of using warm compresses, which I'll show you a slide, and scrubbing around the eyelids and actually milking out the oil from the lids. And that helps to better coat the tear film. I talk to a lot of my patients with evaporative dry eye about their environment. You'd be surprised how much these patients suffer in the wintertime when the heat is turned on very high and the humidity drops. When the heat is on high in the house, those tears will evaporate right off. And many people, when they're sleeping at night, especially during REM sleep, when your eyes are moving back and forth very quickly and their eyelids are slightly opened, their eyes really dry out when they're sleeping. So it's important to have a humidifier in the room if you have this type of dry eye, and to watch the heat in the home. And the other important thing is many patients with dry eye, especially evaporative dry eye, when they're sitting down to read or look at a computer, when you're involved in those types of tasks, you blink 1/3 of the time less. So just by forcing yourself to blink a little more frequently, that can also help your dry eye condition. And a lot of my patients who work in front of the computer 8 to 9 hours a day, this is also very important. Many of the computer screens now are very modern, very large, and many patients are either looking straight at the computer or looking up at the computer. What does that do to your eye? Your eye is completely open, in fact, hyper open. I tell my patients just to lift up their seat and lower their computer terminal so that they're looking down. Why? That'll allow your lid to be closed 3/4 of the way. And if you're doing that for 8 to 10 hours a day, that can make a big difference on how the tears evaporate off the surface of the eye. There are other treatments that we can use, such as punctal plugs, which I will show you what they're about. I talk to them about diet, which really does play a very important role in patients with meibomian gland dysfunction. And specifically, a diet high in fish oil, omega-3, really helps this condition. I also talk to them about different types of medications. Many medications can be drying. Sleeping medications, antihistamines, some blood pressure medications, and granted, many times patients need to be on these medications, but sometimes there are alternatives that are less drying. So I'd go through a detailed history about medications they're taking. And I always want to make sure I don't miss a rheumatologic problem, such as rheumatoid arthritis, gout, Sjogren's syndrome, or an autoimmune condition, or thyroid, because a lot of people with autoimmune conditions also will have dry eye. Just as the antibodies will attack different areas of the body, they can also attack those lacrimal glands that makes the fluid component of the tear film. This is just a picture here. I have some patients with severe dry eye that need to have humidity at all times. And there are humidifiers available for the cars, especially in the wintertime when the heat is on, and you have to keep the heat on because it's so cold. You can actually put a humidifier in your car for people whose profession involves driving for many hours at a time. This has really helped them. Now, the treatment, as I was mentioning, for the meibomian gland dysfunction or blepharitis is not just artificial teardrops. Teardrops will not work in this type of dry eye because, remember, these patients are making enough tears, the tears are just evaporating off too quickly. How do we take care of those oil glands? Warm compresses. What does that do? It loosens up all the debris at the base of the eyelashes and liquefies the oils. The oils are in a congealed state. When you apply wet warm compresses, the oils liquefy, and you have to keep them in the liquid state. And using just a washcloth doesn't do the trick, because once you put a washcloth under warm water and bring it up to your face, it's usually cool after about 5 to 10 seconds. So I have my patients look into getting gel packs that you can throw into the microwave for about 10 seconds. The gel heats up and stays warm for 5 minutes, and then I have them wrap a wet, warm washcloth around these gel packs and use that as a warm compress, and that is very, very effective. That's the first step. Then the next step, you have to clean the surface of the eyelids, and I recommend commercially available pre-moistened towelettes. There's very different types of towelettes you can use. There's foaming cleansers that are made specifically for the eye. I have the patients wrap it around their finger, keep their eyes closed, and massage their eyelids back and forth and push on their eyelids to get rid of all the excess oil that's stuck in the eyelids. Once they start doing this regimen, their symptoms improve tremendously. And then lubricating drops just to kind of get rid of all the debris. But people with evaporative dry eye are not completely dependent on artificial teardrops like the people who are not making enough tears are. Now, in a lot of these patients, meibomian gland dysfunction and blepharitis goes hand in hand with a condition called called rosacea. Many patients who come in with rosacea of their face, 100% of them will have rosacea of their eyelids. And that rosacea of the eyelid, in essence, is posterior blepharitis. And how do I treat that? Same thing, warm compresses, scrubbing the eyelids, but then I will also add an oral antibiotic to these patients, because a lot of these patients take the antibiotic not so much for its antibacterial effect, but doxycycline is the antibiotic that I recommend. That helps with decreasing inflammation in those oil glands and stabilizes those oil glands. And a lot of dermatologists would put patients on this to improve their face. And it also improves the oil glands in their eyelid. And sometimes when the inflammation is severe, I will treat them for a course of, with antibiotic steroid drops or ointments around the eyelids to quiet down the inflammation. But I always am on the lookout for people with rosacea, because many times their dry eye is coming just from their skin. A few words again about doxycycline. It's not used, you don't have an infection. It's not an infection, it's an inflammation. The doxycycline is used not as an antibacterial agent, but more so for its side effect of stabilizing those oil glands. There are some commercially available drops out now that you can apply on the eyelid that are antibiotic drops that kind of work in the same way. And then for the type of blepharitis that I mentioned where mites can be living around the lashes, the root of the lashes, Demodex blepharitis, this is a very tough creature to treat. Antibiotics won't work very well. Sometimes we try to suffocate them with oils, but what works very effectively is a solution of tea tree oil cleansers that are available to scrub around the eyelids to get rid of that type of blepharitis. But once again, you have to be diagnosed with that type. Other treatments for people with pretty severe dry eyes, if they're not making enough fluid, there are oral medications that you can take. And a lot of people with Sjogren's syndrome will take oral medications to help increase saliva production. At the same time, it'll increase lacrimal gland production. There are, aside from artificial teardrops for people with dry eyes, there are certain pellets that you can place in the fornix that's inside that eyelid that are slow-released kind of gel artificial teardrops that will help patients, especially older patients who have to use teardrops many, many times during the day. Sometimes with arthritic hands, it's hard to get these eye drops in, so that might be a good option for these patients. For some of my severe dry eye patients, I'll fit them with a specific type of contact lens. Now, mind you, many people with dry eyes can't tolerate contact lenses because it will disrupt the tears off the surface of the eye. But there are special contact lenses called the Boston lens or the MSD, mini scleral design lens, that are made to sit on top of the cornea. And there's a fluid reservoir between the cornea and the lens, so it bathes the cornea 24/7. They have to be specially fit, but for some patients, this has really relieved many of their symptoms. And then just a few words about, back to dermatology. People with acne rosacea will be treated with doxycycline, but many times the dermatologist will also treat with intense pulse light treatment on the face, and that helps to decrease those abnormal blood vessels. With less abnormal blood vessels, there's less inflammation. And there are some studies to show that if you treat this area of the face, not on the eye, but underneath the eyelid, you can also get benefit in improving the inflammation in the oil glands that sit in the eyelid. And that can also improve their dry eye symptoms. Now, back just to contacts. Like I said, many times people with dry eyes can't tolerate contacts. However, it's very important to, if you want to wear contacts, make sure you're diagnosed with a certain type of dry eye. Once you start the treatment for the dry eye, many times you will tolerate a contact. But you have to use a specific contact, and I'd recommend that you get fit by a contact lens specialist who makes sure that the contact lens is not too loose or too tight, because that will not allow you to wear it comfortably. And there are different types of polymers or plastics that contact lenses are made out of, and some are better than others depending on what type of dry eye you have. And the ProClear is a very good contact lens. The AccuView makes one-day contact lenses. So it's important to, once you have your dry eye treatment regimen going and your eyes are feeling better and you want to wear contacts, try different contacts that have a better water content for dry eye. And many times patients can tolerate. They might not be able to wear a lens for 20 hours a day, but a lot of my dry eye patients, 80% of them are back into contacts wearing them 8 to 10 hours a day pretty comfortably. Now I want to talk a little bit about supplementation. I mentioned to you diet. In general, for the eyes, taking antioxidants is very good. The A's, the C's, and E's, they help various conditions of the eyes. But specifically for those the meibomian gland dysfunction, And for the blepharitis, they have done some studies showing omega-3 fish oil, more so fish oil capsules. If you take 3,000 milligrams a day, which is 3 of those pills a day, that can be as effective as taking doxycycline. And why would it be better to take the fish oil? Well, doxycycline is an antibiotic, and some people can have reaction to it. Some people can have upset stomach with doxycycline, sun sensitivity, yeast infection for women. There are a lot of side effects, even though it does work. So if we can get away from some of these side effects and take a fish oil supplement to help with the meibomian gland dysfunction, that's probably the way to go. The other thing I wanted to mention about doxycycline here, a lot of my patients will come in and have tried doxycycline and have told me they've gotten no relief from it, which is pretty unusual because it's a very effective medication. And the first thing I ask is, how do you take the doxycycline? And they'll tell me right away, I take it with my breakfast in the morning with my coffee and milk, and right then and there I know it won't work, because that medication, you should talk to if you're put on it, make sure not to take it with any milk products or dairy products, because it can bind the antibiotic and it will not work. So other supplements to take for healthy eyes: calcium, vitamin C. So I definitely recommend a multivitamin along with a supplement of omega-3 fatty acids for people with dry eyes, 3 capsules a day. It can thin your blood a little bit too, the fish oil, so if people are taking blood thinners, go over with their cardiologist or the primary care doctor if it won't interfere too much. Now, a few words about artificial tears. You go into a drugstore and you're inundated by all different types of tears. What do you choose? And sometimes very tough. They're all very different, and you have to find which one works for you. But I just want to break it down and let you know that there are really 3 different types of teardrops. Ones that have preservatives in them, which I usually don't recommend if you have dry eye, because the preservative itself can be irritating. Then they have artificial teardrops that have disappearing preservatives, meaning the preservative is in the bottle, but once you place it in the eye, it dissipates into water and oxygen, and you don't get the ill effect of the preservative on your eye. And then the third type is preservative-free, and these are teardrops that come in individual little packets that you rip open and you use for the day, then you throw out. Next time you grab it, you're grabbing a completely new pack with no preservative. And the type of teardrop you choose kind of depends on how severe your dry eye condition is and how sensitive you are to preservatives. And then other teardrops will be a little more gel-like, a little less gel-like, and this requires experimentation because you want a drop that will stay on the surface of the eye but not blur your vision too much. And the way that they interact with the patient's tear film is very different. So it's important to try different drops. Speak to your ophthalmologist about which drop he or she feels may be better for you. But in general, if your eyes are dry, I like to go with the individual little packets, no preservative. And I'll tell you why. This is why. The preservatives, they've done some studies to show that they can actually irritate the surface of the eye. And these are a couple of commercially available artificial teardrops. And this is a study where they took these teardrops and put them on rabbit corneas 4 times a day for about a week, sacrificed the rabbit, and then looked at the surface of the eye. This is what a normal surface of the cornea looks like. You can see this villous structure, and it looks fine, using a drop that has a disappearing preservative. Then when you start putting in a drop that has a preservative that, actually this is one without any preservative. This is now a drop with a disappearing preservative. So you see there's a little bit of a change to the surface of the cornea. But then when you look at the surface of the cornea of the rabbit with a rabbit that has used a drop that has benzalkonium chloride, that's a pretty nasty preservative. Just 4 times a day, it can irritate the surface of the eye. And keep in mind, this preservative is also in a lot of glaucoma medications. So if someone has glaucoma and dry eyes and have to take these drops, these drops can really exacerbate a dry eye condition. Now, companies have become aware of this. So if you do have glaucoma, talk to your ophthalmologist, because there are drops out now that have also disappearing preservative glaucoma drops, or unidose glaucoma drops that you use for the day and then you throw out. And especially if you have dry eye, you won't have that ill effect of the preservative. So that's why it's important to choose the right artificial teardrops. Now, with dry eye, there's also inflammation that comes with dry eye, so we have to control the inflammation. And I usually start with a steroid, but you have to be very careful, because steroids, they can help, but they can have a lot of side effects. So if I use them in short bursts at a time, and I monitor these patients very closely, because they can cause an increase in pressure, they can cause various problems, but they can calm down the inflammation. Now, if they need to be on an anti-inflammatory agent for a longer period of time, and they're the right candidate, I may consider putting them on, and you've seen commercials for this, Restasis, which is cyclosporin. It's an anti-inflammatory, but doesn't have the ill effects that the steroid has. Now, Restasis, that medication is not for everyone. I usually reserve that more for the people who are not making enough tears. That helps to suppress inflammation and gets those lacrimal glands and those goblet cells that make mucus to start producing more of these substances. So I usually don't use it for my patients with blepharitis or meibomian gland dysfunction, but in some situations it can help to calm down the inflammation. So that's also something to talk about with the doctor. I also, with all my dry eye patients, I have a discussion about allergy control. Because anything that's going to cause your eye to become allergic or irritate your eyes is going to exacerbate your dry eye condition. So I make sure I talk to them about their pillows, pets, not to wash their pillowcases with harsh detergents, and also not to use any fabric sheet softeners, because those can be very irritating, especially if you have dry eye and you're sleeping on these pillowcases 8 to 10 hours a night. When you wake up the next morning, your eyes can be very irritated. So I have a long discussion. I talk to them about environment, humidity in the room. There are some patients who sleep with their eyes partially open, so I recommend a goggle system to wear. They'll put a gel in their eye and then wear a goggle that can actually be clear so they can see if they open their eyes. That helps tremendously. And like I said, we talk about different types of medications and seeing where we can change their medication to have less drying. So a little bit more about the Restasis. This works to inhibit a very specific T lymphocyte. The problem with Restasis is it doesn't work right away. You start the Restasis, it takes months for it to have an effect. Why? Because you have to wait for all those activated inflammatory cells to kind of die off, and that can take months. But it won't activate any more new cells, and that's how Restasis really works. So many people think they're going to start the Restasis and they're going to get a great effect. You really don't see the maximal effect until 4 to 6 months. And Restasis can sting a little bit. I tell my patients that. To avoid the sting, if anybody's using that, sometimes keeping it in the refrigerator helps, or putting an artificial teardrop in before you put the Restasis in. But long-term treatment does reduce inflammation in moderate to severe dry eyes, and there's some good studies that patients have done well with Restasis. Now, it's not for everyone. It really is dependent. It really depends on what type of dry eye you have. I just also wanted to mention, through our dry eye center, we're also using a treatment called autologous serum, and this, for some people, has worked in a fabulous way. People who have dry eyes that damage the surface of their cornea, it's sometimes very difficult to heal that surface. And there were some Japanese ophthalmologists that found that substances in the serum, and serum is in the blood, the serum component is kind of that clear component of the blood, has healing qualities, such as growth factors and special vitamins that help to promote surface healing on the skin. So they've done some studies looking at the serum. It's a little difficult to get because you have to donate your own blood, and then drops are made from your blood. But then the blood is spun down and the serum component, drops are made, and you use them 4 times a day. And in many of my patients who have severe dry eyes, I'm able to heal up their surface. And keep in mind, the serum is very close in terms of pH and osmolarity to our own tears. It has extra vitamin, which really helps to heal up the surface, and a couple of other substances which also help with healing. And how is it made? You can't really get this serum in any office. Here at Penn, we have a whole protocol for this. Patients will come in, we draw their blood. The blood is then spun down. The serum is then, under sterile conditions, sent to a compounding pharmacy, and these special drops are made for the patient. And they'll use these drops 4 times a day, and they have to take very good care of these drops because there's no preservative in them. They have to be kept refrigerated at all times. It's like almost like a piece of meat. You can't leave it out because it will go bad if it's sitting out. But the results have been pretty dramatic for patients who have been on these drops. Looking at 7 major reports, I'm just going to kind of sum up here, and a picture is worth 1,000 words. This is a typical cornea of a person with dry eye where we've tried everything, drops, doxycycline, plugs, all different types of things to heal up the surface. And you can see it's not healed. It has all these abnormal yellow spots. After being on the serum for a couple of weeks, you can see that it becomes clear again. So for some people, this works very well. We can see a decrease in fluorescein staining, subjective improvement in a lot of these patients. The problem is, and usually once you get it to quiet down, you can kind of keep it quiet, but if it's very severe, once they come off, these symptoms might come back. So they have to be monitored and treated very aggressively, the patients with severe dry eye. But another option is this autologous serum. I also wanted to say a few words about hormones and how hormones affects dry eye condition, especially in women. 2 large studies were done up in Boston, interviewing about 40,000 women, 22,000 men, and just in these questions, they found that 8% of women and 3.5% of men over the age of 55 had dry eyes. So more women than men. So what can that mean? And interestingly enough, hormone replacement therapy, women who were taking hormone replacement therapy had dry eyes that were worse, had a deleterious effect. And they didn't understand that. And then some studies were done to show that estrogens in this replacement therapy can upregulate the immune response, especially in those oil glands and the lacrimal glands. So excess estrogen can actually inflame the eyelids. So it's very important to have a good balance of estrogen and progesterone. And now androgens, which men have more of, actually downregulate the immune response, specifically in the lacrimal glands and meibomian glands. And when they've done animal studies here where they've taken an animal and rendered it androgen deficient, you remove the androgen, you can see an increased inflammation, decreased function of the lacrimal gland, and these animals developed dry eye. So it's very important when patients come to see me, especially I have a population of even young women taking birth control pills. They have all different levels of estrogens and progesterones, and sometimes the ones that are higher in estrogen, they're not able to tolerate their contact lenses anymore. And sometimes just getting a good endocrinology workup by their primary care doctor or endocrinologist just to stabilize their hormone levels, that can have a great effect on stabilizing the oil glands and their dry eye condition. So as part of the workup when they come to see me, I always recommend that they see someone in our group, an endocrinologist that can look at the hormonal panel, and if it's out of whack, we can put it back into place. And there are also androgen drops that I can use for some women who are very androgen deficient, and I can use these drops to help heal up the ocular surface. So this condition of dry eye, you can see there's so many different causes. It's really multifactorial, and you really need to pinpoint what the cause is of, let's say, your dry eye in order to better treat it. And I have been studying dry eye and doing research in dry eye over the past 15 years, and it wasn't until a couple of years ago I decided to put together this dry eye and ocular surface center that really concentrates on dry eye and aiding to diagnose what type you have. And I have 3 other faculty members that work with me that are cornea specialists. And in our center, which opened up in the fall of 2009, it's doing very well. We're very, very busy. We diagnose with advanced technology. We offer new treatment options, immunomodulators, nutrition. But the big thing here is it's multi-specialty patient care. I work very closely with the rheumatologists because we want to rule out autoimmune, the dermatologist for all my acne rosacea patients or any skin conditions they can have. Oculoplastics, like I mentioned to you, it's very important. The lid has to interact with the eye in a very special way, and if there is an abnormality between the way it interacts, the oculoplastic specialist can take care of that. I work with endocrinologists for the whole hormonal component of dry eye, and with contact lens specialists that can fit dry eye patients with various different types of contact lenses. And the nice thing I think about our center too is, we take the time to educate the patient to let them know what type of dry eye they have and their options. And there's also at our site availability of supplemental treatment. In our dry eye center here at Penn Medicine at Radnor, we have a lot of the products that the patients may need to purchase to better treat their dry eye, which there's a couple samples over there to the left to show you all what that's about. We also give out educational materials, DVDs. We talk about environmental factors. We go through all the different types of lubricating drops, which drop would be better for each patient based on the preservatives and how thick or thin they are. The other thing I wanted to mention also was in some patients when they're very, very dry and they're not making enough tears, another thing that we can do is do what's called a punctal plug, where we can put a little cork in the drainage system of the eye. We have drainage systems in the inner portion of both lids, superior and inferior. And the idea behind that is we can plug up that drain so that the tears you make will bathe the surface of the eye a little bit longer. They'll stay on the eye longer. They won't get sucked up into that drain. And they're effective usually for the people who have tear insufficiency dry eye. They're not making enough fluid. So it's important to know if that's a situation, because plugs really won't work if you have blepharitis. That you can treat with just taking care of the eyelids. But plugs, these punctal plugs, can work with people who are just not making enough tears. And the other thing you should be aware of is punctal plugs is not something that I would put in right away, because many times when patients have dry eyes and they've had dry eye for an extended period of time, the surface of the eye is inflamed. So the last thing I want to do is to plug up that punctum or that opening. Then inflamed tears will bathe the eye for a longer period of time. So I always, if I'm going to put a punctal plug in, I'll always calm down the inflammation for a period of time and then do a trial of punctal occlusion. There are also other products, like I mentioned, there's foaming products to clean around the eyelids, there's different types of fish oils, but I also wanted to mention there are some eye drop that comes, actually eye sprays. I mentioned to you there's some patients who just have a heck of a time putting eye drops in their eyes, so there are sprays that are available that are preservative free for some patients that sometimes is a little easier. And there's also different types of sunglasses that have a little goggle behind the sunglass. And this is also very important too, because people with dry eye, when they're out and about, I tell them to wear wraparound sunglasses, but ones that create an actual seal so that air does not blow over the surface of the eye. Any little air with people with severe evaporative dry eye will bother the patient and they'll become very symptomatic. So know that there's a lot out there, lots of different goggles and glasses and tears and sprays and vitamins that you can use to better treat your dry eye condition. This center that we've opened up has become a large referral center. We have a large patient population. We're involved in about 10 different clinical trials dealing with patients with Sjogren's, looking at the osmolarity in these patients. We're doing a big study on blepharitis. We're also just completed a study of people with glaucoma and taking these medications that have preservatives in them and what effect it has on dry eye. And soon we'll be enrolling patients to participate in a study that is utilizing an oral anti-inflammatory medication to help treat their systemic condition, which could be either rheumatoid arthritis or Sjogren's, but it'll also help calm down the inflammation in the eye. So I can tell you, when I first had an interest in dry eyes 15 years ago, I mean, the only thing that the doctors would say is, take these teardrops, go home, there's nothing that can be done, just use the teardrops. But over the years, you can see there's a lot of attention now for people with dry eyes, trying to figure out what's causing it. There's a lot more treatment options, there's lots of clinical trials, there's a lot of time now dedicated because it's become a big problem, like I mentioned in the first slide. So pretty much lots of different options to between autologous serum, different types of drops, gels. The bottom line is that dry eye is a very common problem, and we need to better understand the pathogenesis and diagnosis and improve future treatments rather than manage through short-term symptomatic relief. That's what was done in the past. You know, take these drops, you'll feel better for a couple of days, but you're not really going to the root of the problem. And in many situations, it's combination therapy, sometimes a change in lifestyle, you know, your diet, what you're eating, your environment, humidity. And therapy definitely has to be individualized with each person. You know, what works for one person might not work for another person. But the most important thing is you have to get an accurate diagnosis. I'm just showing this. I don't know if you all know what this is. This is that magic eye. This will give you dry eyes. If you stare at this and kind of stare beyond it, you can see a 3D image that pops up. I sometimes do this as a dry eye test because you have to stare for a while, and then patients will start to tear, and you can tell if their eyes are dry. But don't be worried if you don't see the 3D image. It's a little tricky to get. My kids love doing this. It's the magic eye. But I am very passionate about dry eyes because for many years it was ignored. Even I trained here at Penn, and when I first trained here, you know, I would even listen to my elders say, you know, just take teardrops, not a problem. But it is a problem, and I wanted to address it. Part of it stems from personal experience. My mother suffered with what I know now is dry eye for many, many years when I was growing up, and our ophthalmologists, which were family friends of ours, told her she was crazy and there was nothing going on in her eye because the signs and symptoms can be very subtle. You can have corneal abrasions and then the next day go see the doctor and they won't see anything. So you really have to be a detective and really look at the lids and look at the cornea. So she suffered for this for many years because each time she'd go to the doctor, he'd say, you have nothing, you know, you're crazy. And it wasn't until I started training here at Penn and I sat her in front of my slit lamp and really took a look at her eye, I was just astonished. She had the worst dry eye, the worst blepharitis. And once we started treatment for her, everything changed. Her quality of life changed. She was able to, you know, go out into the sun, not experience glare or foreign body sensation. So this is an important condition. You know, you may not go blind from it. However, you know, if you have scarring for long periods of time, it could be detrimental to your cornea. But it does affect your whole persona and the way you view things and see things. If your eyes are red, you're not feeling, your whole body doesn't feel right. And this is many of my patients have told me this. Once their eyes are feeling better, they feel a lot better. So I became very passionate about identifying this and treating this and starting this center to help patients with this condition.